Great.
Wide awake? All right. Okay. So we'll go through some check-on learning for thyroid, and then move on to lesson 5. Okay. Which of the following is the main secretory product of the thyroid gland? What does the gland spit out? I hear a D. Anybody else? I hear a C. No E's, right? No E's. Okay. So C or D look right. So it's C. Remember, most of what is kicked out of the thyroid and most of what we find in the blood is T4, and it's that T3 that is that active. And that's kind of just to help with why we rely on T4 a lot for our labs, or free T4 for our labs. So kind of cool when this stuff correlates to our labs. Go. Get it converted into target tissues. And here we're studying whatever concept learning. These are the reasons it's not the other, right? TSH is pituitary, TRH is hypothalamus, and then we talked about T3. All right, a 23-year-old female presents to your clinic complaining of fatigue, bilateral ear pain, pharyngitis, and mild dysphagia. Temperature is 100.1, and the remaining vital signs are within normal limits. Labs include a low TSH and an elevated T4 and elevated ESR. Which of the following is correct with this process of thyroiditis? Viral infection, fluctuant thyroid redness, reverse infiltration, or autoimmune? What do you guys think? A? Yeah. What makes you think alpha? Yeah, the low-grade fever, dysphagia, pharyngitis, ear pain, elevated ESR. Great job. Okay. So we have thyroiditis that hopefully are a little less scary now that we've done some clinical scenarios yesterday, clinical cases, excuse me, and now some questions. So viral, this is what they look like, and this is why it's not what the others would be, okay? Or any of these thyroiditis is more common in males. You'll get your shot though. We'll talk about a lot of male stuff next block. Not so much with thyroid. Which of the following is the most common etiology for primary hypothyroidism globally? C. Come on. Don't forget it exists, and those are those goiters and can lead to the toxic multinodular goiters. Here's the reason why it's not the others. So it's pretty straightforward, but the autoimmune thyroiditis, that's the Hashimoto's, right? That's the most common for the U.S. and pediatric hypothyroidism, right? Which of the following laboratory tests indicate the diagnosis of primary hypothyroidism? So when I say primary, where's the problem? Thyroid gland, right? Primary is in the gland. Okay, now which labs? What do you think? I hear some D. I hear a D. Okay. So primary hypothyroidism. It's B. Here's why. Let's talk about really why. Okay, it's B because primary means the problem is in the thyroid gland. That's hypo, so the thyroid gland is not producing enough thyroid hormone. So free T4 is going to be low. So we look at our options for free T4 or low, and we have really just B and C. If free T4 is low, the pituitary is not the problem, it's working, TSH is going to be high, right? Negative feedback. Okay. 52-year-old woman presents to your office for follow-up on her newly diagnosed hypothyroidism. 8 weeks ago, you prescribed levothyroxine after her TSH was found to be elevated. She's been taking the medication as instructed, and her symptoms are somewhat better. You retest her TSH, and it's still high. What's the next step? TSH is still high. C. Yeah. We're increasing the dose, right? Okay. Look, you guys are ready to write prescriptions, order labs. Here we go. Okay. And then for studying, again, do we give Armour thyroid? No. Barb, you do? Don't do it. So funny. I'm going to share a story that one of you guys told me. They had a fellow boot camper who presented in myxedema crisis. So hypothyroidism presented in the crisis, which is really rare. And they gave him on. This was maybe 11 years ago, if I'm remembering right. But yeah, we're going to use Levifur. Okay. Oh, also, you guys also told me that somebody knew was given Armour thyroid by like a homeopathic clinician, and they may not have even had a thyroid condition. So again, completely weird stuff out there. Use the research, use guidelines, all that. Okay, we're not going to decrease it. Maintaining current dose. So you technically, I guess you could maintain it if they feel really great, or if it's an elderly patient. But that's not something I'm going to do you on a test, right? There's like clinical nuances that go to that. So the best answer is the one you all selected. And then obviously we're not going to take them off, switch them to an anti-thyroid med. So, good. Which of the following would indicate a sign or symptom of hyperthyroidism? So metabolic knob is turned up. Hyper. E. Yeah. Yeah. So you guys know it here. You're going to know this stuff on these too, right? Use those signs and symptoms to paint the picture. Something happens. I remember when we go to a test, it's like, oh, blank. Not this time. Okay. Which is the most common form of thyroid cancer? A. Yeah. Don't pick E. Okay. All right. Any questions? Thyroid is a lot. It's the big one with Cushing disease. We're going to revisit that a little bit and expand on it a lot. We're going to talk about adrenal insufficiencies. Of course, there's a primary and a secondary. Hyperaldosteronism, which is a totally different hormone and different topic. And then the last one, try to stay with me if we get to it, congenital adrenal hyperplasia. It's super cool. This is the end of the slide. It's a Friday test day, but we'll talk about it. I'll introduce it here, and then we'll talk about it more in block 2. All right. We have our first patient, 38-year-old female. Initial thoughts on her, just like general appearance, visual cues. Yeah, potentially like moon face maybe, but it also could just be, see that was excess weight, right, in the face. What else? Plethora, so that's that reddening, potentially, right? What is it? That's right, yeah, you're right. She looks like her skin is, if she's not sweating, oily skin for sure. Can we see any like fat pads from this view? Yeah, potentially. What would you want to do to like get a better idea, right? For the buffalo or we wanted to remove the blouse. And then look, what are we looking for on the abdomen? Striae, right? Central obesity. For what hormone is in excess, do you think here? Cortisol, potentially, right? Okay, so she's presenting with difficulty losing weight. She's been working really hard for the last 3 months, but has steadily gained over 20 pounds. She feels fatigued and has having difficulty sleeping. All right. It's kind of like non-specific symptoms and very, like these are common things that people complain about and struggle with. So get a set of vitals. What do you think of that blood pressure? It's high, right? So we have an elevated blood pressure. And BMI is 32, so class 1 obesity. Oh no, last menstrual period over 8 weeks ago. So is that normal? No. So we can't just ignore that either. Okay. So again, the PA who did the physical exam agreed he had the rounded appearance of the face. Notable terminal hairs on the upper lip and chin. So that's just like the male pattern hair growth that they noticed on a physical exam. Also seen it could be hirsutism. Truncal obesity with purple striae. Oh, okay. And then various spots of ecchymosis in various stages of healing. So that the bruising. Okay. So we painted this elaborate endocrine picture, right, with a cluster of signs and symptoms that aren't super specific, but then we use the physical exam. What are you guys thinking? Still cortisol excess? Yeah. And so far, all we've learned about is Cushing disease, right? Cushing disease is that ACTH dependent. 90% of the time it's due to an adenoma in the pituitary, right? So secondary hyperfunction. Good job. they cut that, and here she is after treatment. So she had a transcommodal resection, right? That's the treatment for these guys. And maybe 3, maybe 6 months. We say like 3 months after surgery, more like 6 months. This is what she looked like, okay? She had her resection of the adenoma, doing better. Everything really improved except for the striae. Even her vitals improved, but they don't always improve. So a lot of times as PCMs, you have to monitor that hypertension. Any questions on this? Bringing you back to a little bit of what you already know about cortisol. Okay. Adrenals specifically, this is, my reviews when we go to anatomy are pretty brief intentionally because you guys already had this, but good review. So we have our cortex and our medulla. The cortex is responsible for secreting aldosterone, cortisol, as well as androgens. The androgens topic is going to be heavy next block. Okay. This is what we're reporting. And the regulation of cortisol is determined by ACTH. So ACTH from the anterior pituitary is released and tells the adrenals, specifically in the adrenal cortex, to produce cortisol. ACTH has some regulation with aldosterone, but we'll talk, there's another system that controls that a little bit more. Does this feel like review? Or is it like a long time ago? Not too bad. All right, so this is kind of your, I think of like your stress response. So on the left will be our last lesson, but on the right is the cortisol pathway, right? So stress can happen, and it's important that our body responds to it, and this is what will, this is the pathway. I talked about this one again, right? So ACTH is released to the anterior pituitary, goes to the bloodstream to the adrenals. The adrenals produce cortisol. Once the homeostasis is reached and we have the right amount of cortisol, we have that negative feedback loop pop up. What I talked about. The medulla is next. Here's us. You guys can teach this to me by now, right? Okay. So again, when we're stuck on a test or we're trying to figure out which lab, just utilizing this normal feedback loop is helpful to us, or will be helpful to you. All right, corticotropin releasing hormone. So this is the hormone released from the hypothalamus, the control center, to help the pituitary release ACTH. Okay, just awareness on that. Secretion of CRH matches the secretion of ACTH, right? So like an illness, surgery, exercise. What is that? What is an illness, surgery, trauma, starvation? What does that all have in common? Yeah, stress, right? So some kind of stress to the body. Exercise is good stress. We like that. We want that. Hypoglycemia, also stress on the body, right? So again, not all stress is bad. We need cortisol. Cortisol gets a real bad rap these days, but it's important as long as it's not an excess. Okay. All right, ACTH. Again, that's your hormone from the anterior pituitary. It is secreted in a diurnal pattern. What does that mean? It's not on the slide. What does that mean? Okay. Yeah, so it's higher in the morning, and then over time it decreases and it's lowest in the evening. So we're going to use that, okay? So again, diurnal means higher in the morning and then lower throughout the day and overnight. So one way to potentially remember this is those of you with kids, or those of you who don't have kids and have just had a cold recently, you can relate to this too. But you have a kid who has a fever, and usually you can manage their fever just fine during the day, right? But what happens at night?
Worse.
Yeah, the fever is worse. It's harder to control, potentially. Maybe you have to give Motrin plus the Tylenol, right? And there's multiple reasons why, but one of the reasons is with the circadian sleep rhythm and cortisol together. Cortisol goes down, so we lose that anti-inflammatory response. The immune system picks up and is more active, and then the fever goes up, okay? So you feel sicker at night. It has to do, part of why it has to do is that dip of cortisol. So maybe that helps you remember, diurnal. Okay. And again, it tells the adrenals to produce cortisol. It plays a role in the production of aldosterone, but the RAS, or the renin-angiotensin system, is the primary driver for that. Stimulates melanocytes, talk about that in insufficiency, and then obviously we know the fever. Any questions so far? Nice review. All right, so cortisol, makes sense that cortisol is also released in a diurnal pattern, right? Because it does what, it's gonna follow the pattern of ACTH when everything's working correctly. So highest in the morning, lower at night, and the same triggers, right? Stress to the body. We secrete this. Again, you need this. This is a good thing. It's helpful. It's expected. And then here's your graph person. Here's another graph. You can see how the pattern of ACTH is in red, cortisol is in green, and the peaks and flows of that with food, maybe exercise, but then obviously dipping at night. Sleep's important. You need sleep. Lots of stuff happens at night with sleep. Hey, you guys might get sleep tonight. Yeah.
Just out of curiosity, does the body utilize cortisol differently during a REM cycle or something? Like, and that's why?
Probably. I don't go into that
still
as much.
Detrimental.
What's that?
Those levels, like for somebody who might have already imbalance, it'd be even more detrimental to sleep theoretically.
Oh, for sure.
So
cortisol, growth hormone,
yeah.
Testosterone, lots of things we need. That so if you're not getting good quality sleep, like from say you have sleep apnea or something like that, it can mess that up for sure. I just don't know the exact of what cortisol with REM sleep, but if you don't have good sleep, you have a disruption for sure. Okay. All right, so cortisol is important for, so far we know, anti-inflammation. It helps with immune system suppression. It also helps with metabolism, right? Increases blood glucose with gluconeogenesis in other places, right? So cortisol is really important. But when it's in excess, we have inflammation is suppressed too much and immune system is suppressed. Now this is in excess. So knowing this, we can use this so that with our prescriptions, right? So if you have someone with asthma who is in this inflammatory state, we give them steroids to kind of suppress it, right? Or someone who had a transplant or bone marrow, something like that, we can suppress the immune system with cortisol. So we can use that in our advantage, but when the body is doing this due to a disease, it can cause problems. And we'll see that we can correlate this to some of the symptoms we see in Cushing's. In addition, bone formation is suppressed, and so if I have decreased calcium absorption, what am I at risk of? Yeah, osteoporosis, that little picture right there. What else am I at risk for based on that picture down there?
Freaking.
Yeah, truncal obesity, okay? And you know from cardio that the abdominal obesity is linked to a lot of diseases. So osteoporosis, truncal obesity, and then immune and inflammation suppression. That's again excess. If there's too much of it, it can affect the skin. So again, those people with bruising, the people with Cushing's are more susceptible to like fungal infections and things like that, slow healing, all of that. And then for sure the mood, altered mood and behavior can occur, especially because you're struggling with something going on for 5 or so years and you don't know what it is. There's that probably plays a role too. All right, so good review of cortisol and all the reasons why it's important, but why it's a problem when it's in excess. So we're going to go into Cushing syndrome. Remembering Cushing syndrome is that blanket term for high cortisol in the blood, so hypercortisolism, okay? And then, for whatever reason, they decided to name one Cushing disease and one Cushing syndrome. Cushing disease is typically in the dome. It could be ectopic, but typically in the dome. And Cushing syndrome, which we'll learn is ACTH independent, is typically a problem with the adrenals. But they produce the same. They present the same exact way. So if these guys present the same way, we need to use labs, right? We're going to use labs and imaging to help us get there to figure out where the problem is. Okay, so etiologies of elevated cortisol, exogenous. What does that mean? Who's causing the problem?
External.
Yeah, we are. Those clinicians that are trying to give them steroid injections for their back, or maybe they have like significant rheumatoid arthritis, and so you give them daily prednisone or something. So long-term high-dose corticosteroids are the most common cause of Cushing's syndrome. And then we have the endogenous causes, right? So it's in the body. And we already know ACTH dependent, which is that excess ACTH is causing high cortisol. And then we're going to learn more about the independent, where it's autonomous cortisol production, meaning the adrenals are producing extra cortisol independent of ACTH, right? Okay, so you guys feel good with ACTH dependent? I said it, dependent, dome, disease, you guys got that? 90% of the time it's that pituitary adenoma, other 10% it's a cancer or ectopic. And then there's two endogenous, so non-medication triggered ACTH independent, and that's an adrenal adenoma. So you have an adenoma on the adrenals that's just causing excess cortisol to be released. ACTH is not in control, right? That adenoma is acting completely independent. Or adrenal hyperplasia, so that's when the adrenal glands get bigger. With that increased growth, there's increased activity and synthesis of cortisol. Okay, so those are our two new causes we're going to talk about. For the ectopic, this will come to play when we talk about imaging, but most of the time, those ectopic causes are in the lungs again. There's other places too, so if I have someone and they have ACTH dependent hypercortisolism, I think the problem is in the brain, and I do what? What imaging? If I think it's an adenoma in the brain, what imaging do I give? An MRI, right? There's MRI is normal. Where should I look based on this list here? What should I do next?
Lungs?
Yeah, I want to look at the lungs and the abdomen. So I'm going to do a chest CT or an abdominal CT, right? Because I looked up here and it's normal, That accounts for 90% of ACTH dependent or Cushing disease. I don't see anything. I'm waiting for endo, of course, but I'm going to do some imaging looking for cancer somewhere else, likely the chest or the abdomen. Here's a summary slide that hopefully you'll appreciate towards the end. Okay, just like Cushing disease, Cushing syndrome takes a long time. Usually you see 4 clinicians before they get the diagnosis. Hey, this is the exact same slide as lesson 3 because we know these present the same. I think you guys have got that, but don't forget the mood stuff, hypertension, acne, the oily face that we saw in that first video. Same photo. All right, what do you see in her? It's a female patient. I don't know her range. What do you notice?
Redness.
Maybe some obesity. What about her face? Some acne. Yeah, hirsutism, right? Is this nil pattern hair growth? For sure, the acne and things like that. Good job. We need a full exam. So let's look at Tony. So Tony, I apologize, I can't remember his weight, but he's coming in because he keeps gaining a lot of weight and a lot of weight fast. Also, yes, acne, he's annoyed by these stretch marks, mood swings, specifically anger outbursts, so he's agitated. At the same time, he's feeling weakness. He's dislocated his ankle a few times. He's bruising a lot. What do we think is the problem? Excess what? Cortisol, right? That's all we talked about so far. Right. Okay, so, correct. Here is what happened. So he had hypercortisolism. It was confirmed with a dexamethasone suppression test. We'll say a 24-hour urine. And then they did the ACTH level to see where is the problem. And the ACTH was really high. So if ACTH is high and cortisol is high, where am I looking? Where's the problem?
Usually brain.
Yeah, the dome, right? Because ACTH is high and cortisol is high. We know it's the dome because technically ACTH should be low when cortisol is high, right? Okay, yeah, so the problem's in the dome. So they did an MRI and it was negative. And then they did the abdominal CT, it was negative. And it took a while, but they finally did a lung CT and he had lung cancer. So that was the treatment. So with a 90-10, just FYI, that's for females. Men, the ratio is a little bit different. But current says 90-10, but technically in real life, that's just for females. So for my test to be, I'm going to stick with the 90-10, but just don't forget for ectopic causes, okay? All right. This is just kind of a summary slide. Again, it's like where the goal when you think someone has Cushing's is you need to really get there. You need to verify that Cortisol is in a diurnal pattern, and so the best way to do that is with labs. Yeah, that's really, don't memorize this, but at the bottom is real life. This is so true. Conflicting results are common, but not on my test. All right, so cortisol is produced in a diurnal pattern. We know lots of things can cause it to be released. We know in excess, there's no real good range of quantifying excess cortisol. So if I can't just do a cortisol lab for excess, what do I do instead? Remember that fancy test where I give them a steroid and see what happens? Yeah, dexamethasone suppression test. So just to dust off the cobwebs, we'll go over this somewhat quickly. But we take a steroid, we expect the pituitary to make less ACTH, right? Negative feedback loop. If ACTH goes down, then the adrenals make less cortisol. And we expect a normal human to have low cortisol or less cortisol after the dexamethasone suppression test, okay? Cushing syndrome and Cushing disease. What do you think is going to happen? Give the steroid, ACTH should go down. Cortisol should be less by the adrenals. But that doesn't happen. There's more, because the problem is the adrenals are doing what they want. They're acting freely of the negative feedback loop, freely of the anti-pituitary, and they're making excess cortisol, either through hyperplasia or an adenoma. So they see here, this is in the first slide, the labs are the same as far as dexamethasone, okay? Both result in more cortisol. Again, the labs are exactly the same for to confirm hypercortisolism. You need two. You need a dexamethasone suppression test, it's very easy to do, 24-hour urine cortisol, or a late night salivary cortisol. We need two of those to confirm hypercortisolism. This is a review, just in case you need a review of what the dexamethasone suppression test looks like. All right.
They are given two of each test, so I have to do it twice.
You only have to do one, so you could do dexamethasone and a urine, and that's it. So two of the three, or you could do a urine and a salivary test. So you just need two out of the three. You could do all three, but only, if you did all three, only two would have to be positive to meet criteria. Okay, so sometimes in a test question, what I'll do is I'll paint a picture and I'll say the patient's hypercortisolism has been confirmed. And all that means is that those initial labs have been done. Okay, so if those initial labs have been done, do I know if it's syndrome or disease? Not yet, right? I just know they have high cortisol, but I don't know where the problem is. And so in order to find out where the problem is and what's to blame, I need to do an ACTH, okay? ACTH is gonna tell me is it dependent or independent, okay? So that's what differentiates Cushing disease and Cushing syndrome. DHEAS is the FYI. It's just like, again, I mentioned it's a more stable lab, and maybe in the future I'll be teaching DHEAS is that lab that we use. But for right now, ACTH points me in the direction. Is it a pituitary problem? So where it's dependent, or is it independent of the ACTH and the adrenals are misbehaving on their own? Does that click? It doesn't click when you study, come and see me. All right. So nice little recap. So causes of hypercortisolism, something is secreting excess ACTH, means it's ACTH dependent, right? So we've said this over and over again, Cushing disease or ectopic. ACTH will be high. Independent, so this is the new. So this is excess cortisol is not due to ACTH hypersecretion, right? It's independent of the ACTH, and that is either, if it's an adrenal cause, it's due to an adenoma or hyperplasia, right? Kicking out excess cortisol on its own. Or the obvious way would be to get a really good medical history and make sure they're not taking steroids, okay? So here's, the next few are all summary slides. This one and the next one are my favorite. This one just talks about labs. My final one talks about everything all at once. So we've had a confirmed hypercortisolism, right? So that means dexamethasone suppression test is elevated and their urine, 24-hour urine cortisol is elevated. So I know I've done my initial labs. I need to lean on the ACTH to tell me where the problem is, okay? When you see ACTH is elevated with ACTH dependent, and it's going to be low with independent. Okay? Because remember, ACTH independent, the pituitary gland is working like it's supposed to, right? If cortisol is high, ACTH should be low, and it's telling, and so that lab being low tells you the pituitary is working correctly. And the problem is where? The adrenals. Okay. Sometimes if you think of like, where's the problem, it can help you. Here's a table that runs through each version. Again, normal. The second one is a pituitary adenoma. Third one is ectopic. And the last one is an adrenal adenoma. This, it was there before I took this and or took over this class. I left it and just like cleaned it up a little bit. But if you like flowcharts, it's just the same thing I've been saying in a little flowchart. And then here's kind of the final, everything on when to do. And again, remember, so I do the ACTH, it's elevated, telling me something, I think something's wrong with the pituitary. There's pituitary adenoma, so I'm gonna do a brain MRI. That makes sense, right? That's a review of what we already talked about. Okay, crap, I do the brain MRI and it's normal. Well, Endo's gonna do this fancy test, but I'm gonna look for cancer or an ectopic cause in the lungs or the abdomen. All right? On the other hand, I have a patient who's hypercortisolism, but the ACTH is low. That tells me the pituitary is doing what it's supposed to do in this situation, so the problem is in the adrenals. So where should I focus my imaging on? The adrenals, right? We're going to do a CT of the abdomen or adrenal CT, and it's going to tell me, oh, there's an adenoma or bilateral adrenal hyperplasia. Okay. This, I think, is like a nice money slide or good slide, but you have these all versions too. Differential, sure. If we were ClinCore, maybe, but we're okay. So this is the treatment. There's a treatment of a table, and there's a treatment. Both of these slides say the same thing. They're just organized a little bit differently. So let's go through each one. I think you guys will like the treatment. I hope they make sense to you. So if I have a patient with hypercortisolism, and they are taking, the reason is because of excess cortisol use, or I'm giving them steroid injections. How do I treat that?
Stop.
Yeah, stop. We're just slowly stop. We're going to very slowly taper them off, reduce the dose if possible to fix the problem, right? Think of the, what's the comedian actor's name? I forgot. That I showed you at the beginning. Amy Schumer? Is that her name? Yeah, think of her, right? Okay.
Sure.
So, sure, why not? Obviously, I can't remember her name. Okay. ACTH producing pituitary adenoma Cushing disease. You guys already know what we do to this. What do? We treat with the surgery, right? Transfenoidal surgery. Ectopic, well, there's a tumor. We potentially picked it up from a chest CT or abdominal CT, oncology, thank you. Take it to that, hopefully they can treat that and fix the problem. Or two new things we learned about is an adrenal adenoma. So if there's just a little adenoma on the adrenal, we're gonna go to surgery, okay? Either they can remove the adenoma or maybe a unilateral adrenalectomy, okay? They've still got one good adrenal. Now, if it's bilateral adrenal hyperplasia, the problem is both adrenals, and so we're going to go to medication first. Okay, meds first, because there's a lot more risk if I take out both adrenals than if I try a medication first to calm down the excess steroid production. Regardless of what they have, when I treat this, I need to be prepared for cortisol withdrawal. So these patients, even though they are in excess, they're probably going to need some cortisone replacement for a short period of time. And I think that will kind of make sense of the picture I have in the future. All right, same thing, just again this way, if you like this better. If you go down to bilateral adrenal hyperplasia in both, I say adrenalectomy versus meds. You don't need to know the medication, okay? Just know that medical management is ideal for that. Again, here's the meds. I'm not putting you on this. Did you learn these in farm? Cool. You don't know. That was redundant time. So that's you won't have to one less med. You have to relearn. We'll say relearn. Prognosis. If we don't treat, if a person with Cushing's goes untreated, it's really, really bad, right? The cardiovascular disease, diabetes, insulin resistance, stroke, infection, right? We learned that about infection and how cortisol, excess cortisol plays a role in that. But if they have the Cushing disease, they do a lot better than ectopic. That makes sense, right? Because the cancer. And again, when should we refer? It's at the bottom. The minute you get that elevated dexamethasone suppression test, you're going to refer. But you can still do the ACTH, you can still do the MRI, the CT, get all that worked out before you go to endo. Questions on that? That is Cushing syndrome disease all wrapped into one. If you don't get this when you're studying, let me know. On the review, I'll do, it's cheesy, but it works. I'll do like a feedback loop on the whiteboard probably. And that gives you guys a chance to study a little bit, and then maybe it'll come all together. And if you can do what I do on the whiteboard and teach it to somebody, you should be okay on the test. All right. We got some time. Okay, so adrenal insufficiency, shifting gears. What's the title tell us? Right? Cortisol is what? High or low? It's low. So we have obviously John Kennedy there. The picture there is my friend's dog. Any opportunity to put a dog up there. She actually had Addison's. It presented like type 1 diabetes. She unfortunately did not make it very long after that diagnosis. But yeah, it turns out it happens to dogs too. So primary adrenal insufficiency. Where's the problem? Primary adrenal. The adrenals, right? The organ is the problem, and that is also known as Addison's disease. But it's the chronic deficiency of cortisol by the loss of function of the adrenals. Okay. The most common etiology of Addison/primary adrenal insufficiency is autoimmunity. That's all you need to know. Okay, it's an autoimmune cause or destruction of the adrenal cortical cells. You can also, like a TB infection, HIV, other things can cause it, but all I need you to know is autoimmune. I kept this on, or I added this, I added this I think last semester, but I think it's crazy. So you have to lose 90% of cells in both adrenal cortexes to have significant clinical manifestation. The body's pretty cool. It can really compensate for a long time. Adrenals, are they very big? No, they're not that big. But super, super important. Okay. So if I say the most primary cause of primary adrenal insufficiency is autoimmune, it should also make sense that they're at risk for these other autoimmune disorders. You don't have to memorize this list, but probably good. I think you guys all know that these are autoimmune. Not maybe. It would be more like it would help you in the story. I might like paint a picture with this, but I wouldn't say name another autoimmune disorder that Addison's patients could get, right? I wouldn't do that. It would this would be like added to this scenario to help you get there. But as you see, we'll go through the signs and symptoms. You probably need it. Just like the other conditions, it develops gradually, months to years. So a lot of times the diagnosis is delayed because it's non-specific. So some people will have this gradual presentation, and I guess technically some can have a sudden onset. But the people who are gradually, it's very non-specific. They're tired, they have loss of energy, weakness, and weight loss. But the weight loss isn't super significant, so they're not going to be coming in for that. A small percentage of people will present an acute adrenal crisis, okay? So we've talked about that with thyroid storm. Most of the time, they already know they have Graves' disease, but they can't technically, the first diagnosis can be presented with a storm, same with mixed edema crisis. Again, most people, it's gradual, but acute adrenal crisis can be that initial presentation. And you do not want to miss that. So much we don't want to miss that we're going to talk about it again here. Signs and symptoms. So if I lack cortisol, I'm going to have weakness, a weight loss, hypotension, especially like positional dizziness or lightheadedness is common. Hyperpigmentation. Remember that cross-reactivity. So if cortisol is low because the adrenals aren't working, what's ACTH going to do to you? Negative feedback. Cortisol is low because my adrenals pooped out. It's up. So that high ACTH in adrenal sufficiency cases, that high ACTH will actually cross will increase the MSH, and so they'll get a hyperpigmentation. And it can be generalized hyperpigmentation, I'll show you pictures where it's all over, or it'll be on the creases of their hands, look in their mouth, on their gums. Also, it can be really mild with scars, where new scars will get darker, or their freckles will get darker, okay? So, and then on their creases, so the bra line, the axilla, the groin, those areas can be dark. The GI symptoms is really common for acute adrenal crisis, as well as the gradual presentation, so nausea, vomiting, diarrhea. Vitiligo, what's vitiligo?
Patches.
Yeah, the opposite. So you can have someone with hyperpigmentation and vitiligo, where vitiligo is hypopigmentation. So you can have both. I have a picture of that. Anxiety, irritability, and depression. 40% of people with Addison's were told it was just anxiety. So that's another piece to the puzzle. Myopia is a big one too. All right, here's that. Why these people are have hyperpigmentation. This is from lesson 3. The common cross-reacting things highlighted there. So here is your hyperpigmentation with vitiligo. This woman, would you know that she has Addison's? Or is she just scared to get a spray tan or something? Yeah, so maybe like pictures before and after make a big difference. So with darker complexion, you're gonna look at, again, the hands, the feet, and then look at the tongue and the gums. You see the hyperpigmentation? Both sides, so this is just the dorsal side of the hands, the palmar side is really helpful too. I think that's, yeah, in the next picture. Maybe it's hard to see the palmar on this one, but it's there. And then just the pattern of hyperpigmentation on the dorsal side is irregular. What about this lady? She look hyperpigmentation or no?
Yeah.
Kinda, maybe, but like if you've never met her before, or if you were just like passing her in the airport, would you know?
No.
I don't know. Right, here's her after treatment. Whoa, now like, if you were looked like the picture on the right and then switched to the picture on the left, then maybe you would come in. But it's gradual. I got another story. So this is a 54-year-old man. He came to the ED, he was confused, abdominal pain, nausea, vomiting. He's been diagnosed with chronic kidney disease. He's hypotensive. He's a little bit tacky. Again, his abdomen is really tender. Would you guys think this guy has Cushing's? No, right? He's hypotensive, abdominal pain, and he has these GI symptoms. So they do a sugar on him. He's hypoglycemic, so his blood glucose is low, and he's hyponatremic. So they're focusing on fluids and trying to fix the sugar, but he doesn't get better until they get a cortisol on him, and his cortisol is super, super low. So he's presenting with acute adrenal insufficiency, and that's how he presents with picture A. What he looked like before Addison. So this is his, say, 4 months ago, 6 months ago, Addison's treatment. So this guy, again, he was seen by his PCF. They were treating him for chronic kidney disease and things like that. And it didn't get caught until he went into more of a crisis study. So, you guys will like labs on this. Okay, so if cortisol is low, because the adrenals aren't working, what should we check? We'll just check cortisol and ACTH, right? When should I check cortisol? If it's a diurnal lab. It's most predictable in the morning because we know it'll gradually decrease. And I don't want to do labs in the middle of the night because unless you're in the hospital or you're going to find a lab tech who's going to do that. Right? So we're going to do morning ACTH and morning cortisol. Okay? So we expect it to be low, right? Low cortisol. That makes sense. And with a primary adrenal insufficiency, where the problem is the adrenals, ACTH should be high, right? Does that make sense? Because the pituitary is working correctly. When cortisol goes low, ACTH goes up. And it's like, hey, adrenals, we need more cortisol. The adrenals are like, hey, man, I don't work no more. Autoimmune got me. I don't work. Okay. We're going to talk about the confirmation test a couple times. But look at these additional lab findings, lots of hypos, hyponatremia, hypoglycemia, anemia, right? That's this guy, right? He's hyponatremic, hypoglycemic. The true root of the problem was the adrenal insufficiency. So these patients are going to have some mild irregular labs. Don't let that scare you from what the problem is. Because remember, we're in endo, so I'm not teaching you about anemia on the test. I'm teaching you. Okay, so don't let the hypos and or hypers deter you. Okay. So here is our annoying but fun endo test. It's called the cosinotropin ACTH stimulation test. So cosinotropin is synthetic ACTH. Okay. So if you have someone and you're not sure if it's an adrenal issue or maybe a pituitary issue, we're going to give them ACTH. So we inject them with cosinotropin, and we see what happens to cortisol. All right. So in a normal person, I give them ACTH. What should cortisol do? It goes up. But in a person who adrenal glands don't work, that doesn't happen, right? It's going to stay low. Questions about that? Okay, we'll go ahead and take a break. We'll go into secondary. If I look and I give you someone that looks like this, weak, hypotensive, hyperpigmentation, anorexia, does this person have excess cortisol or low cortisol? Low, right? Just remember that. I know what on the test it gets confusing because I'm talking about an insufficiency and an excess. They have the same labs. Lean on this, okay? Remember, they look clinically very, very different. Same with hyper and hypo. Clinically very different, same labs, okay? All right, secondary adrenal insufficiency. So primary is the primary problems is the adrenals. This one, you might immediately go, oh, it's a pituitary problem, right? Maybe there's a tumor, or maybe trauma, radiation. Pituitary is the problem. Okay, so they're not. The problem is again with the ACTH. But the most common cause of secondary adrenal insufficiency, so cortisol low, is where you have someone who's on chronic steroids and they just stop them. So let's think about this. I have a patient who's taking exogenous corticosteroids. If I'm taking exogenous corticosteroids and I have my cortisol at this level, what do the adrenals do when I'm just feeding my blood cortisol? They don't have to work as much, right? They just take a little nap. So they're going to turn off. Okay, so my cortisol is right here. What does ACTH do when my cortisol is up here? It's low, right? It wants to stay in homeostasis, right? So then I have this cortisol, and then I'm like, oh crap, I watched this video or this TikTok thing that said chronic steroids is a bad thing. I'm going to stop those. Or I have a PA who's like, or let's go and who's like, you shouldn't be on chronic steroids. I'm going to stop those. And they don't taper it, you're going to have a problem. Okay? And the reason why we're going to have a problem is because the minute you stop those corticosteroids, so we have months after stopping glucocorticoid treatment and the concentrations of ACTH and cortisol on this graph. I stop here. Look how long it takes my anterior pituitary to kick back up into normal range. A long time, right? We're not even almost to like mid-normal at 6 months. So look, my adrenals and my pituitary got to nap. And then look how long it takes for my cortisol to okay. Look how long it takes my cortisol to get into normal range. 10 to 12 months. Okay? So again, if you can't, yes, exogenous steroids can be hazardous because they can cause Cushing syndrome, but we can't just stop them because it's going to take the adrenals a long time to catch up. And honestly, if you talk to endocrinologists, it sometimes it takes even longer than just a year. Okay. I was reading this thing, and they did a small study in California where they weren't taking prescription glucocorticoids, but they were taking supplements. I think it was for like joint pain, so osteoarthritis stuff, and it had a significant amount of glucocorticoids in it, or very close to it, and they ran into this, and it was really, really hard to get them reset. Really hard. Okay. And again, here at the bottom, secondary makes sense, right? Pituitary is the problem down there. Signs and symptoms are exactly the same. Hypotension, non-specific GI symptoms, weakness, anorexia, weight loss, except there's no hyperpigmentation, right? Because ACTH is not super high, right? Because ACTH isn't high because the pituitary is the problem. Okay? Or if the pituitary has been napping because they've been on such high corticosteroids for so long. Alright? So instead of hyperpigmentation, they often will be like pallor or like alabaster skin. Alabaster skin just seems like a really light color. So the signs and symptoms can help differentiate between the two. Labs are the same. We're going to do a morning cortisol and a morning ACTH. Morning cortisol is low, right? Because we're in adrenal insufficiency and they're presenting that way versus an excess. And then, okay, great. ACTH again. This is like the 8th time she's talked about ACTH lab. All right. So if it's low, it indicates there's a secondary pituitary dysfunction, right? Because when cortisol is low, ACTH should normally go up, but it's not going up because there's a problem with pituitary, or the pituitary is napping and it's really trying to get back up, but it can't. It takes 4 to 6 months to do that. Okay. Additional labs, usually electrolytes are normal. So remember with primary, with Addison's, they had hyponatremia, hypoglycemia, different anemias, not so much with these. Okay. And then, of course, it makes sense if there's a pituitary problem that they might have other hormone deficiencies, but I will not do that to you on the test. Here's our cosinotropin ACTH stimulation test. So remember, we're giving this person ACTH, synthetic ACTH, and we want to see what happens to cortisol after. So in a normal person, if I give them ACTH, cortisol goes up. But in a this is where it gets tricky. Stay with me. In secondary adrenal insufficiency, newly diagnosed, it stays low because of this table up here, right? It stays low because of adrenal suppression and atrophy, okay? Remember, it stays low because pituitary, it takes so long for us to get back, for basically the adrenals to wake up. The adrenals are snoozing, okay? So that makes sense. All right. Let's compare the two in a nice summary. So primary, so we're used to with Addison's, hyperpigmentation. We know what that looks like. We're not going to be worried about the hyponatremia, hypoglycemia, hyperkalemia. And then ACTH is going to be high, right? The problem is my adrenals aren't functioning because of an autoimmune disorder, but my pituitary is doing its best. Other side, no hyperpigmentation. In fact, they might have alabaster skin. Or again, they might have just stopped taking a high dose of corticosteroids without a taper. Electrolytes are nice and normal, but their ACTH is low. Okay. I'm not going to do inappropriate normal, it's just going to be low, okay? Questions on that? Low because the problem is pituitary, or low because those steroids, because of those long-term steroids, pituitary, it takes a while to wake up and start working. So when we look at this, the most helpful lab again is that ACTH. ACTH, just like in Cushing's, same with adrenal, it points to where the problem is. So when we do the review, and I get this whiteboard over here, hopefully somewhere where everyone can see it, if you draw out the feedback loops, hopefully that can help you on the test. Or whatever else, if you have another idea, you can do it. Just don't make fun of my drawing, so it's going to be real simple. Okay, not like my Halloween costume. Way more simple. All right. So cosinotropin, we've talked about this a bunch. I'm just going to do it one last time, and then this just explains why it's low for both. Okay. Again, we expect when we give ACTH, synthetic ACTH cortisol to go up, but it doesn't in primary because adrenals don't work, and it doesn't in secondary because they've been nappy, they're suppressed, they're atrophied. Okay. Or the pituitary system. Imaging hopefully makes sense. So primary problem is the adrenals, their hyperpigmentation, all the things we're gonna go straight for the abdominal CT, right? Or adrenal CT, we're gonna go straight there and we're gonna see these atrophied adrenals, okay? Secondary, let's look at their meds, even their supplements, right? Let's see if they're, or did they tell you, they admit that they've just cut their meds cold turkey for whatever reason. And then if there's no medication or supplement history of any glucocorticoids, let's look at the pituitary for a problem. Imaging makes sense with Cushing's and an insufficiency, I think, I hope. All right, so we identify they have adrenal insufficiency. We know because their cortisol, morning cortisol is low, and the ACTH, either low or high, points to if it's primary or secondary, as well as their past medical history, medication history as well, and their signs and symptoms, right? How they present. How do we treat it? Let's give them what they're missing, right? We know we need cortisol to live long, healthy, functioning lives, right? Because stress happens, our body's under stress quite a bit, so we need cortisol. So we're going to give it to them, we're going to give it to them twice a day. Typically, the morning dose will be a little bit higher than the afternoon dose. You don't need to know the doses, but does that make sense? Why would I want it to be higher in the morning, right? We want to mimic physiologic diurnal pattern, okay? For people with primary adrenal insufficiencies, because those adrenal glands are so atrophied, we need to also replace the mineral corticoid, okay? So we'll replace that as well. And then DHEA is supplement. People who have Addison's who take DHEA feel so much better. That's like quality of life, because when DHEA will mimic ACTH, so anyway, these people just feel so much better on this supplement. Okay, I'm not going to test you on that, maybe one day, but not now. Just for clinic, Addison's, give them that supplement too. Quality of life, all of that stuff is included. Okay, so increasing glucocorticoid dosing during stress. Why do we do that? Mimicking physiologic, right? If I have a URI, if I have pneumonia, if I'm in a motor vehicle accident, I need cortisol to be increased, right? Right? It's a normal thing. So you need to counsel your patients. Hey, if you get a UTI, maybe if you get a shingles vaccine, or you have a cold, I need you to increase your dose of glucocorticoids. So this is called sick day rules. Okay, you either double or triple the dose. Okay? And then of course, if you're throwing up and you can't keep food down, you should probably get seen, right? Because then if you're throwing up your pills, you can't get the cortisol that you need, so you're at risk. Does that make sense? Sick day. If I have a nice basic cold, I'm going to increase that. Now, if I have severe trauma, significant motor vehicle accident, or surgery, then we need to bring the big guns and we'll do IV cortisol, okay, followed by infusions. That makes sense? It kind of correlates with the stress. And then as they get better, that cold, that self-limiting virus runs its course. My internal bleeding is stopped, I am discharged, then we'll go back to normal, okay? If you don't give these patients cortisol when they need it, they will die. And a lot of times they will have these med bracelets. And if you read this one, it's really funny. Amber, adrenal insufficiency, steroid dependent, right? My adrenal glands do not work to generate steroids. Give drugs or watch die. Kind of dark, but also very direct, which I appreciate. So these patients, just like you give a type 1 diabetic, glucose tabs and glucagon and things like that, you're going to give these patients an emergency steroid kit. You need to counsel the patient on when to use it and their family. Why? The patient might not always catch it, right? So their family needs to know as well.
This is more.
Secondary, just the glucocorticoids. We don't usually need to do, because aldosterone isn't effective. And that's because aldosterone, if it's a pituitary problem, the primary drug for aldosterone is a different system. It's the RAS system, okay? The renin-angiotensin aldosterone system. Treat the underlying pituitary disorder, and they also need the steroid kit, the sick day dosing, that sort of thing, okay? That's it for just insufficiency. We're going to go into this acute adrenal insufficiency or adrenal crisis. This is one of those things you just can't miss in life and in clinic, okay? So just like I think there's a few of those in neuro and probably in every class, this is a big one. I've alluded to it a couple of times with the pituitary apoplexy already. So immediate threat to life, right? So they'll often come to the ER with like abdominal pain, vomiting, fever, but it's not a GI thing, it's adrenal crisis, okay? And it could be somebody who, if you're lucky, you have a patient who's like, I have Addison's, I have a bracelet, I am sick, and then you're gonna be like, oh, I know what this person needs, they need steroids. But again, every now and then someone can come and present to the ER, and their initial presentation or diagnosis is made an acute adrenal insufficiency. Remember that gentleman where we showed the 3 pictures of him? He's that example, okay? So remember, they thought he was hypoglycemic or if it was his sodiums, but it was actually adrenal crisis. So this should make sense. It overlaps with what we learned about with thyroid emergencies, right? Stress, infection, trauma. Sudden withdrawal of glucocorticoid therapy. I just stopped my meds for there's various causes why people stop their meds. Sometimes there's no reason, they just decide to stop. So again, patient education we know is super, super important for our adrenal insufficiency patients. Adrenal trauma, surgery. There's that pituitary apoplexy, right? That presents with a sudden headache, vomiting. They usually have a history of an adenoma. We need to give them steroids right away before any other hormone. So when I look at this list, weakness, hypotension, fever, nausea, vomiting, dehydration, I kind of go to like a shock type presentation. So a lot of times that sometimes in your protocols, corticosteroids might be kind of given. Not in your classic ALS. When you take ALS, it's varied by the book. But again, you have this dehydrated person, you're giving them fluids, they're not responding to fluids and pressors. Adrenal insufficiency or crisis might be on the differential. And then it gets worse, right? Confusion, delirium, coma. So this is important. If adrenal crisis is suspected, you need to treat them right away. IV access, and we need to give them hydrocortisone right away. Yes, in an ideal world, we're going to wait for a lab and we're going to do all of that stuff, but especially if they know they have Addison's, something, or you're concerned about adrenal apoplexy based on their history, don't delay steroids, okay? Now, typically, if they're brought by ambulance, we're getting labs, we're kind of getting labs at the same time as we're doing the assessment, right? If you've ever been in a trauma, they're cutting the patient's clothes off, they're assessing the airway, someone's getting blood, all of that stuff is happening all at once. But we don't delay the steroids. Summary of treatment. We're not just doubling their dose or tripling their oral dose, right? If we know they have Addison's, no, we're giving them immediate hydrocortisone, and then they're going to follow IV, and then they're going to have an infusion. Fluids for sure. These people are dehydrated. I already mentioned it. When we looked at the signs and symptoms, they present maybe like a hypovolemic shock, right? Or even septic shock or something. So these guys need fluids for sure. Guarantee their electrolytes are all over the place. And then typically broad spectrum antibiotics, because especially if they have a fever or if it was that bacterial infection that caused this flare. What do you think I'm going to focus on? What do I want you to focus on the treatment? Yeah, steroids, right? Identify that this is an acute adrenal crisis. I'm going to paint that picture, and don't delay steroids. Prognosis, obviously, the earlier you catch it, the better. Need fluids, need to be monitored. And that's really the key is recognition, right? If we don't recognize them, they will not make it. Because they need more than fluids and pressors. They need more than glucose, okay? All right, that's it for adrenal, all things cortisol, okay? We're going to talk about aldosterone, and it might overlap with a little bit that Dr. DeBoer learned, and if we have time, we'll talk about an androgen thing. We'll probably skip the clinical cases because it's Friday. We'll see. We'll see how fast I talk.
Yes.
We'll see. Oh, it's 20 after 8. We'll see. All right. Okay. So there's mineral corticoids. The hormone we're talking about is aldosterone. Yes. Who loves this stuff? This RAS stuff? Anybody? I thankfully don't have to love it for endo. I'm just going to use it as a reminder. So we know ACTH plays a role in aldosterone release. It's produced in the cortex of the adrenals, but the primary driver is your renin. Renin, where are you at? Renin, angiotensin, aldosterone system. Excuse me. Okay, so there's a drop in renal perfusion, and renin is triggered, released. Renin goes up, triggers angiotensin, which triggers aldosterone secretion. Okay, aldosterone plays a role in sodium, potassium, and your water absorption. So look exactly what that is. Just in it. Here we go. So cortex, yep, we got it. Higher as aldosterone increases through our RAS system, potassium goes down, water and sodium goes up. Okay, so we have that nice homeostasis, and then it cuts back. There's another beautiful flow chart of the same thing. Yeah. Okay. So there's our feedback loop. But we're going to talk about diseases, right? We're not just stopping here. We're going to talk about diseases. Only one disease related to aldosteronism, and it's primary hyperaldosteronism. So we're talking about hypertensive patients. So 5 to 10% of your hypertensive patients have hyperaldosteronism. And these are going to be those patients that have high blood pressure that are just resistant to treatment, refractory, or they have severe high blood pressure and their potassium is low. Okay, or they're like a young patient. This should be, we're looking for a secondary cause. It's the #1 hormonal cause of secondary hypertension. So vast majority of patients with high blood pressure have what? Primary essential hypertension. So we're talking about secondary. Just like we did in acromegaly, Cushing's, hyperthyroid, right? These hormonal causes for hypertension. The last point I added, I went to a conference this summer because why we care, cardiovascular events are more prevalent with people who have hyperaldosteronism. So we need to catch it and treat it. Then they're going to have less MIs, less strokes, less deaths, right? So excess aldosterone from the adrenals. This is renin independent. So it's not the RAS system that's causing this. It's not renin's fault or angiotensin 2. No, it's inappropriate aldosterone secretion from our favorite adenoma or hyperplasia. Okay? So where's the problem? In the adrenals due to an adenoma or hyperplasia. You don't need to know the percentages. All right, how do these people present? Hypertension, for sure. I already said moderate hypertension. Don't worry, I'm not going to it'll be clearly they have hypertension, not just diastolic. Hypokalemia. So this is usually found instantly. So you have a person with blood pressure and you've been seeing them for years. What do we check regularly, right? A CMP. Do we want to do a GFR to check their kidney function? And oh, interesting, the potassium's changed, right? So we have hypokalemia. But so when I was in school, this like hypokalemia and hypertension was like, that was it. But honestly, there's only 37% of people with hyperaldosteronism have this hallmark finding. So the vast majority have normal potassium. It's probably because the body's really good at achieving homeostasis, so it compensates. So again, even if their potassium is normal, they're young, they're not hard to control, think hyperaldosteronism and do some extra labs. Other things, these symptoms here are kind of related to the low potassium, but they could have them anyway. But headache, cramps, muscle weakness, tired, because everybody's tired on Friday afternoons. It's all endo's fault. Okay. All right, so again, this is just, I think I've said all of this. Who we need to think about hyperaldosteronism for. A family history is also that, or where you have a primary relative with it. Okay, so if I have hyperaldosteronism, I'm a patient with hypertension, I'm concerned. We're probably going to look at the potassium, right? We know that. But we have some other labs that will help us. The first is PRA, or plasma renin activity. This is how we measure what renin is doing, right? So we know hyperaldosteronism is due to an adenoma or hyperplasia, right? It's renin independent. So if aldosterone is high, what do we expect renin to do? From that feedback loop, it's gonna be low, right? It's like, dude, we don't need any more aldosteronism. I'm gonna go down low. The adrenals are doing what they wanna do, independent of renin, okay? We're gonna check potassium, you know why? Aldosterone, we're gonna do these labs in the morning. And of course, because it's endo, we can have this 24-hour urine that we can consider for confirmation. The information in that FYI block is just that PRA is finicky. You don't need to know that, but there's really specific rules that lab has to do when we work with them. So again, I said this alright. So already, renin independently. Inappropriate, unregulated aldosterone secretion from the adrenals. Potassium, 37% will be low. Aldosterone's high, that makes sense. PRA is low, right? PRA is low. And then obviously, 24-hour urine would be elevated. If you have someone with hyperaldosteronism, you also would run some genetic testing, but I'm not going to quiz you on that. Or the ratio. These labs kind of make sense? All right. So based on the problem, where should we have our labs. Our labs are indicating hyperaldosteronism because aldosterone's high, PRA is low, maybe the potassium is high, they have hypertension I can't control. Where should I focus my imaging? Should I focus it on the brain MRI or the CT? The CT, yeah, of the adrenals, right? Yeah. It'll be CT, not or MRI. It'll be a abdominal CT. Okay. Just to make it like consistent through the whole course, I'll stick with CT. And oh look, there's a little adenoma there. No good. Thank you, arrow sign. Okay, so again, this is treatable hypertension, which is really important to identify it through labs and a good history. And we're going to use medication to treat this, specifically spironolactone. It works really, really well for these patients. It's affordable. We prescribe it a lot. And it's considered first line, specifically for people with bilateral adrenal hyperplasia. Because what happens if I take out those adrenals? Then I'm dealing with someone who I have to do corticosteroids to, sick day rules, all of that. So if I can try a pill first and treat not only their hypertension, but their hyperaldosteronism, I am happy, okay? Yes, spironolactone does have an anti-aldosterone activity, so men might get gynecomastia, libido changes and things like that. But spironolactone is still your first line. The Pilaron I've never actually prescribed. Current has it as like an option, but it costs a lot of money. So spironolactone is the realistic clinical answer. But technically, there's that. I think there's one other one too. You guys know. There's a third one. And then if the adenoma is the cause, and it's just this little adenoma that's causing all this excess aldosterone, you could do surgery removing that adrenal gland, okay? And then obviously we want to control their blood pressure. So that's it for hyperaldosteronism. Pretty straightforward. I know we use these terms again, adenoma and hyperplasia, but the treatment is pretty similar. And you guys already know about spironolactone. You know about RAS. We love RAS. Okay, this is the last topic. It's about androgens. Stay with me. Just scratch this first slide. I wanted to take it out and I didn't. Okay, so we're talking about androgens because you know the adrenal cortex produces cortisol, talked about that, aldosterone, yep, and then androgens. This specific disorder, congenital adrenal hyperplasia, it involves, there's a lack of an enzyme needed to make cortisol. So it's an enzyme deficiency is the problem. So we're going to go through some flowcharts of kind of the enzymes that are needed to get to cortisol. And so again, these patients lack a specific enzyme, 21-hydroxylase, required to make cortisol. Now, real world, there's multiple enzyme deficiencies, but we're going to focus on the most common, which is 21-hydroxylase. Okay, I'm going to do a picture instead of reading this, and hopefully it'll make sense. Okay, so here we are, deep inside our cortex, and we're looking at the pathway to making cortisol. Okay, so ACTH goes up, tell the adrenals, hey, we need more cortisol. Perfect. We're going to go through these lovely hormone or steroid pathways, but shoot, there's a deficiency in 21-hydroxylase, right? So if I have a deficiency of there, I can't make, depending on how significant of the deficiency, I'm going to have less cortisol. What, based on this, what's going to be in excess? What lab do I check? Yeah, 17-hydroxyprogesterone, right? That's a precursor. And if we go down this path, but I can't get past this step because there's a deficiency here, I'm going to have excess hydroxyprogesterone. Well, at a certain point, this is going to go and go to androgesterone, which is a precursor, which is close to testosterone, okay? So again, we can't get as much cortisol. So I'm always 17, I got a lot of 17, but I never make it to 21, right? Every teenager wants to be 21, but they're 17, they're stuck there. Just again, this is what's missing. And this is the enzyme. Is this the lab I'm going to do? No, that's the enzyme. So the enzyme is 21-hydroxylase. The lab is 17-hydroxyprogesterone. Okay? That essentially is what this says. If you like to read it later. And close your tongue. Okay, so there's two types of CAH. Classic, which is severe. These are babies born, there's a significant deficiency, so they're hardly making any cortisol at all. And just like our babies with creatinism, which is that failure to develop the thyroid, we screen for this in the newborn screening. So we are going to catch this with the newborn screening if what? If they're born in the United States or a country that does newborn screening. The non-classic is more common of what you may see in clinic. It's super interesting. But it's not a full enzyme deficiency. So they're still making some cortisol. So you're not going to notice a problem until pre-puberty and puberty. And I'll talk more about this in block 2, but for now I just need you to be able to identify congenital adrenal hyperplasia, understand what enzyme is playing a role and what lab, and that's it. Okay? So again, if I have a baby who has classic CAH, it means no, there's almost complete lack of this enzyme, they may not make it, right? They could die as newborns or in utero. And females will have ambiguous genitalia. So it's like clitoromeglia. You're just not quite sure. It doesn't quite look right. It's viralized. You need to know what viralized means. It refers to like development of male-like characteristics in female babies, okay, or females, okay. So clitoromegaly or ambiguous genitalia is common. And that, again, we do the newborn screening first, so we'll catch that right away. Somehow we missed it on physical exam. And then our non-classic, remember, they're making some cortisol. But what's going to happen is they're making some cortisol, and like around 8 or 7, we start to have like, what are signs of pre-puberty? What do kids have, like early puberty? How do we know they're going through the change? What do boys do? Hair, right? Armpits are stinky, acne, right? Women will be hairs, breast bud development, pubic hair, axillary hair, right? So we have that happen, but with these people, it's going to potentially will happen even earlier. Why? Because we have excess 17-hydroxyprogesterone, which when we have excess of that, it's got to go somewhere, and so it goes and produces more of this testosterone and more of those androgens. So that's why they're going to have hirsutism. They're maybe hypertension, irregular cycles, or no cycle at all. Again, I just need you to be able to identify like, oh, that looks like that. Can you see how this ambiguous genitalia is different than the baby with no thyroid? The baby with no thyroid is a puffy face, the large tongue, what else? They have cognitive impairment, growth impairment, versus a girl, or usually a girl, with low hypothyroidism. With the girl with low hypothyroidism is coming in because she's not doing as well at school anymore, she's not growing, maybe irregular menstrual cycles, but she's constipated, fatigue, hair loss. Do you see how that's different than a pediatric with congenital adrenal hyperplasia? And then what labs do we do? We know. What's in excess? 17, right? 17 hydroxyprogesterone is high because there's a deficiency in what? 21 hydroxylase. Treatment is for your situational awareness. We're gonna, but I mean it makes sense. So if they're not able to make cortisol, we're gonna give them some cortisol. Right? Contraceptives, that spironolactone is super helpful for these non-classic. So you're done with lesson 5. I have 15 minutes for clinical cases. I will not be offended if you guys want to go. Otherwise, what do you guys want to do? I think
Leave.
leave.